Ladies and gentlemen, a very good morning. I'm extremely sorry for not being able to be with you this morning, and I realize fully well that I will lose the opportunity to learn from all of you. I honestly feel that the remit of this morning's plenary is critically significant because we all recognize the importance of factors outside of the healthcare system in improving health outcomes. We all know, for instance, that per capita income is one of the strongest determinants of health status achievement, and that as opposed to this, there is very little independent correlation of health status with the number of hospital beds or doctors. So the first point I'd like to make this morning is to stress that the best way to improve development outcomes is through sustaining growth, increasing employment rate and per capita income, and by addressing core social inequities. And I've tried to make that point a centerpiece in my book, which was launched day before yesterday at this meeting. I feel that it has absolutely become an imperative that we in the health sector work together with other sectors to ensure that innovative approaches are deployed in macroeconomic management, in revenue collection, and in the broader governance domains of civil services and public finance management to ensure that more resources are available for the health sector and are used better. This morning, I'd like to focus on three areas to demonstrate how innovations outside of the health sector can be leveraged to improve health systems' performance. The first is the area of health financing. We are all, of course, aware that innovations in resource mobilization are at the heart of many high-level efforts aimed at augmenting the base of resources for health in the developing countries. There are several innovative options in various stages of being explored and tested and deployed in that regard. The International Finance Facility for Immunization, for example, leverages pledges of governments' future donations for upfront cash on financial market bonds to support Gavi. This approach entails an interface with financial markets, which is totally outside of the healthcare system. Another example is that of the Debt to Health initiative, where a creditor relinquishes the right to partial repayment of previous loans on the condition that the beneficiary recipient country invests the freed up resources in approved programs of the Global Fund. And here again, the innovation is principally in the area of creating a new instrument for debt relief, which is outside of the remit of the health ministries and in health-related international agencies. It is the Ministries of Finance and Economic Affairs which have to work with counterpart bilateral agencies to secure debt relief. But the impact, of course, is directly on the health sector. And similarly, since we are talking about health financing and exploring situations outside and leveraging innovations, it must not be forgotten that the solution to financial risk protection against health hazards, which is the ultimate desired outcome of health financing, lies not directly with the health sector, but more directly with employers in the labor market, who the health sector must learn to engage and must try to influence through regulation initiated at the broader governance level. The potential within all these opportunities, as you well know, is often not fully appreciated. There are also many other examples around the world where earmarked taxes are being levied to support health. Unitate, for example, is a successful example of an airline tax which is levied to secure access to treatment for HIV/AIDS, malaria and tuberculosis. Tobacco taxes in Thailand is another example. And in these areas, the health sector needs to work with the Ministries of Finance, Taxation Department, revenue mobilization teams, reserve banks to make that happen. There are other examples where incentives are being created to stimulate private research and development in manufacturing, such as through prize funding mechanisms and advanced market commitments. And here again, the point of leverage is in the financial sector through financial instruments. All of these examples represent innovations in financing with reference to fund mobilization and augmenting the base of resources. But I am personally of the opinion that these should be paralleled with innovations in governance to improve targeting and utilization in order to limit pilferages and leakages from the system, which are pervasive in the developing countries. And it is in line with this belief that my organization, Heartfile, is currently in the final stages of deploying a cash transfer project which leverages web and mobile phone technology to mainstream transparency, both in the use as well as in the targeting of social protection funds. We will be testing this in a randomized control design, and we hope to be able to make the results available to all of you in the first quarter of next year. And it was actually in the creation of this model that I realized how important work outside of the health sector actually is, because we had to work not just with software experts and learn about issues of intellectual property and the potential within open source technologies. We needed to interface with banks to secure the right prerogatives for an equity fund that we have created. We had to talk to mobile service providers to tap into payment options. We had to learn about Pakistan's central banking regulations in order to comply with them. And hopefully in the future, we hope to be able to shape philanthropy legislation and related systems in the country as a result of the benefit that we are able to show. All these things are critically relevant to the health financing tool we are creating, but they are completely outside of the health system. The second thing that I'd like to talk about relates to the many opportunities for innovation in the space of service delivery. You may be aware of the bottom of the pyramid approach to marketing, which the cell phone industry has capitalized with great success. There is of course a caveat here because of the public good character of the interventions in the space of health, but we must recognize that some of these constraints which limit the scope of private provision can actually be overcome through innovation. Most of the innovations that we talk about in this space basically involve learning from the private sector's entrepreneurial talent and their incentive structures. And there are many examples where these insights have been used to increase the affordability, the availability, or quality of health services. For example, Aravind eye hospitals now sell an intraocular lens for less than $5 and still supply 10% of the global demand. Many institutions have been able to radically lower the costs of prosthetic devices, such as in the case of Jaipur Foot in India and PPOS in Pakistan. And others use high volumes to bring down unit costs, as in the case of the Narayan Haruyudayala Hospital for cardiac surgery. Similarly, in the domain of service delivery, innovative use of philanthropic resources have supported services with huge outreach. In Pakistan, for example, the largest ambulance service is run totally by a trust, the Eidi Foundation, which is completely outside of the health sector. Citing another example from my country, a partnership with a microcredit enterprise has been quite successful in revitalizing the management of the state's crumbling primary healthcare infrastructure, with actually some very encouraging initial results. All these examples show that innovative approaches that involve private and public roles and which can involve outsourcing and learning from private sector's experience and cross-subsidization, or managing supply chains, or franchising, or practice audits, or streamlining and optimizing associated processes can actually bring a lot of value to the health sector. But we need to work with sectors outside of health to be able to make that happen. My third and last point, and perhaps that is where the greatest potential lies, relates to mainstreaming technology in healthcare systems. Many developing countries have made investments in telecommunication infrastructure. They have improved broadband connectivity and are experiencing a mobile technology boom. And we must recognize that through appropriate linkages with these sectors, we can revolutionize learning, continuing medical education, we can radically change information dissemination, we can control costs and human resource errors in clinical settings, we can improve connectivity in health information systems in today's environment where disease security is a burgeoning concern. We can make telemedicine work for remote settings, as we demonstrated in Pakistan when a devastating earthquake claimed more than 80,000 lives in 2005. And I can continue to go on and on with how PDAs can improve the quality and speed of services and how technology can bring value to mobile kiosk services and so on and so forth. But what is relevant for this panel today should be the realization that in technology and indeed in each of the six health systems domains, there are clear opportunities to derive benefit for the healthcare sector by working intersectorally. The challenge now for the health community is to explore those opportunities and develop policies, institutional frameworks, and normative arrangements that can facilitate intersectoral engagement. We cannot improve health by working in the health sector alone, and I think this should be an important systems policy takeaway message from this important conference. I thank you all.